Hello, everyone. My name is Gurjat Basra, and I'm the Manager of Patient Programs, Research, and Advocacy here at Lymphoma Canada. I'm pleased to welcome you all to the first live session of the day titled Lymphoma 101 for newly diagnosed patients. Just before we start, I do want to go through a few housekeeping items. So this Zoom software does not allow you to access your camera or your microphone. So if you do have a question, please enter it into the Q&A chat box at the bottom of your screen. Additionally, I know many of you may be wondering, so I'll just mention it right at the start that this webinar will be recorded and it will be available on our website shortly after the conference. And you will also receive an email with the links to access these recordings. With that said, to introduce our speaker today, we have here Dr. Guinevere Davies, who is an assistant professor at McMaster University and is a malignant hematologist at the Juravinski Cancer Center in Hamilton, specializing in lymphoma, autologous stem cell transplant, and CAR-T. She is the division head for malignant hematology, and her research interests include population and health outcomes for patients with lymphoma. So thank you, Dr. Davies, for joining us today, and you can get started as soon as you're ready.
Great. Thank you so much for inviting me to participate, and I'm very happy to go over Lymphoma 101 for newly diagnosed patients, which is obviously a conversation I frequently have within my clinic. These are my disclosures. And so our objectives today are just to look at the definition and causes of lymphoma, look at the common classification system, review standard workup and staging, and also discuss a broad approach to treatment, appreciating that you're going to have specialized sessions later today, kind of learning more in depth about each of those treatment modalities. So the first question is, what is lymphoma? I think a lot of the time, healthcare practitioners might think that patients' understanding is sort of beyond where it is, or again, it's very good to sort of get back to basics. And I always include kind of my thoughts about lymphoma and explore people's understanding of it when I'm seeing patients for the first time, as well as their family members. So this is just your lymphatic system. So this is a circulatory system made of vessels, which are similar to blood vessels, but they carry lymph. So lymph is the actual fluid, and the purpose of the lymph is to travel throughout your body. It goes, into lymph nodes and into the other lymphatic tissues. And it not only cleans up after cells, but it's also sort of circulating and carrying lymphocytes. So these are blood cells that participate in your immune system, and they actually can carry these immune cells into your lymph nodes. And the whole purpose of your lymphatic system is to, again, help carry away these waste products, but also to help fight against all sorts of different types of infection, which can include bacteria, viruses, and other things like that. So, probably most people have heard of a stem cell before. So these mainly hang out inside of your bone marrow. And there's cells that can actually go and grow into all different types of mature blood cells. So they can go down sort of the left side of this pathway, and these are all the different types of cells that they can grow into. So they can go down what's called the myeloid side and become mature red blood cells, platelets, neutrophils, or they can go down the right side of this picture, which really shows how they can mature into what's called lymphocytes or natural killer cells. And so all of these different types of cells work together as part of your blood system. And what we're really going to focus on for this lymphoma talk is the right side of this. So how the lymphoid stem cell grows into the lymphoblasts and into these mature B, T lymphocytes and also natural killer cells. And so I always talk about all these different cells. They interact with each other in different ways. They form different parts of the immune system. So for instance, the B lymphocytes can make antibodies, whereas the T lymphocytes, a lot of times they can actually go and kill an infection that you haven't previously been exposed to. And also natural killer cells, part of their job is looking for infected cells and also for tumor cells to help fight against those. So when you have mistakes happen in sort of different blood cells, then that can result in all sorts of different blood cancers. So this is just actually showing that. So this is a sort of complex picture, but it's essentially showing that, when you have what's called an antigen, or that's an infection or something else that your blood cells might respond to, these naive or sort of unexposed blood cells, they go through this whole series of changes. And the changes lead those blood cells to be actually able to fight that specific infection. But during the course of all these changes, there's a lot of pressures to, make antibodies, to be specific, to cycle through your lymph nodes. And so because a lot is happening, this sort of leaves the door open for a lot of mistakes. And so you can see, depending on where the mistake happens, where the cell is in its journey, that can result in different types of lymphoma. And that kind of leads us to where we are, where we have more than 70 different types of lymphoma. And it's really important when we're doing our biopsy and our workup to really understand exactly what type of cell we're dealing with, and that can tell us a lot of different information about how we're going to treat the lymphoma and also what the prognosis is. So again, this is just a couple of different types of lymphoma. Again, there's many different types, and it's really important to understand what type of lymphoma you have. But this is just to show you that, again, those white blood cells, the lymphocytes, they can travel through your lymphatics in your lymph to all different sites of the body. And the thing with blood cells is that really they can go anywhere. So you can get all different presentations with lymphoma, which is a little bit different than a lot of the solid organ tumors. So this is just a picture showing Burkitt lymphoma. So this is the endemic type that individuals in sub-Saharan Africa can get, that's associated with the Epstein-Barr virus. This is showing you CT imaging of a patient with effusion lymphoma, which is commonly associated with HIV and can cause fluid collection around the lungs and the heart. This is actually a type of skin, or what's called cutaneous lymphoma. And this is after it's been treated with radiation. So again, just really, if we're for any lymphoma doctors or health providers, they've really seen it all, because again, lymphoma can present in really a lot of different ways. So, this is just a very broad description of how we sort of break down lymphoma. As as things have evolved over time, we've really learned a lot about lymphomas, including looking, even at the DNA or how those lymphomas grow. And previously we would have classified lymphomas just on how they look. But now we know so much more, and we've really become very nuanced in categorizing it. So the way that we categorize lymphoma is just constantly evolving. But this is the broad way that I would categorize it, is so when we talk about mature lymphomas, which is at the bottom of that picture of the blood cell maturity, really I say there's Hodgkin and there's non-Hodgkin. Within Hodgkin, which is about maybe 10 to 15% of lymphomas, commonly they're classical, and these are the different types. This is quite rare, this nodular lymphocyte predominant. And within non-Hodgkin lymphoma, the majority are B cell, and much less common are T or NK cell. And then further within B cell, we have what's called these indolent lymphomas, which they're frequently slower growing. So some of them we don't even need to treat right away. But on the flip side, we generally think of them as not curable. But there's, patients within this category who even have a normal lifespan and will eventually pass away of something completely unrelated to their lymphoma. So, there's a huge variability. On the other side of it is these aggressive lymphomas, where we really think that we need to treat these individuals right away. And actually, frequently our goal is to cure them. Within the T and NK cell, there's a lot of, again, different ways that this can present, whether it's the cells like to stay in the blood, where we actually are calling a leukemic type of non-Hodgkin lymphoma. Otherwise, sometimes they involve the skin, such as with mycosis fungoides, or even in the intestines or in the lymph nodes. So a lot of times people will ask me, is there something that I did? Is there something that I was exposed to? And it's a little bit challenging, because again, there's so many different types to say, yes, this is the thing that really increased the risk of you developing lymphoma. But they have tried. So this is actually looking at, they looked at 17,000 patients, and I apologize, this is just non-Hodgkin lymphoma. But they looked at 17,000 patients, and then they looked at, I think, 23,000 people who did not have lymphoma. And they said, what increases your risk? And so this was just an observational study. And so where you see red, that is increased risk of developing lymphoma, whereas blue are more protective factors. And so we see that, a family history of having a blood cancer does increase your risk for a lot of these. Having an autoimmune disease can increase your risk for lymphoma. This listing here is hepatitis C does increase your risk for certain types of lymphoma. And then interestingly, atopic disease such as eczema or allergy, even interestingly, alcohol consumption can decrease your risk of lymphoma. So we do know a little bit about some of the risk factors. But I think the next question that follows on to that is there a screening test? So, for instance, that your family member is affected. And so what we say is that there's no actual validated test to screen for lymphoma, such as a mammogram, a FIT test, a PEP test, or anything like that. However, there's no specific guidelines, but if you had a family member with a blood cancer, or you had risk factors such as a previous organ transplant, etc., it is reasonable to think about asking your provider for a lymph node exam and a blood count. Realistically, if you have no symptoms, this might not be very helpful. Even if you found one of those slow-growing lymphomas, you may just cause yourself anxiety and not need treatment. But I think this is a reasonable sort of one-time measure if you did want to think about something to investigate yourself. So the symptoms of lymphoma can be quite varied. I'm going to talk about B symptoms on the next page, which you see in lots of material on lymphoma. Obviously, the classic thing would be enlarged lymph nodes, which can happen in your neck, your armpits, your groin, feeling tired or out of breath, feeling full after a few bites, or having pain in your belly, and that can be related to an enlarged spleen. With Hodgkin, you can actually get itchy skin. Sometimes it's quite significant, or where people actually have a rash on their skin from scratching. Infections that don't go away or they keep coming back. And even sometimes patients are referred to us with changes to their blood tests. So we can see low red blood cells and platelets, too many lymphocytes, and so that's more common with one of the types of non-Hodgkin lymphoma called CLL, where actually we see that the white blood cell count is increased in the blood, lower white blood cells, and then sometimes if patients have had testing for another reason, we might see that they have a test called LDH, which is elevated, or this beta-2 microglobulin, which again is more commonly done. Actually, it's a screening test along with the LDH and to prognosticate patients. So B symptoms, they can tell us how fast your lymphoma is growing. So these are more common with the aggressive lymphomas. And I kind of say it's like the cancer cells are kind of shaking and stealing your calories, and that can lead to these symptoms. And so people can get these drenching sweats where you're actually soaking your bed or soaking your clothes. Sometimes people can lose weight, so losing 10% of their body weight or more without trying. So they're eating normally and they're just losing weight, or even a fever that keeps coming back and is not otherwise explained can be seen. So certainly if we're seeing you initially, or if we're following you up and watching for progression or recurrence, it's really important to let us know if you're experiencing these symptoms. So, as we're working through, the workup for yourself or for a patient with lymphoma, you're going to have blood work, as we talked about before. So this would not only look at your blood counts, but it would also look at your kidney, your liver tests, also looking at your electrolytes, looking for any funny abnormal blood proteins. Again, we would be doing infectious screening. So actually, I screen everyone for hepatitis B, C, and HIV. I have been surprised previously, and it does really impact treatment and care, so it is important to do that. We'll also be proceeding with imaging, and so imaging is really important if people have symptoms, to sort of investigate and see whether there's a mass or a lymph node that might be causing those symptoms, as well as to complete staging. And then finally, we'll talk about it a bit more, but pathology. So sometimes we don't have quite all the information from whatever was done initially that sort of raised the alarm about lymphoma. So we might have to proceed to a larger lymph node biopsy, like an excisional biopsy, or we might have to complete a bone marrow biopsy as part of the diagnosis or staging. So this is just an example of actually what a normal blood smear looks like. So you have all of your red blood cells, which are these little red circles. We have our platelets, which are the sticky little things that help us form a clot. And then we can see all different types of white blood cells. And so this is what a normal lymphocyte would look like. You can see that the middle is about the same size as a red blood cell, but they're all kind of different types of white blood cells. And then what you can see on the right panel is that there's many more lymphocytes than we would expect. And so this would again sort of raise the flag that there's some abnormal cells there. And we even see these things that are a little bit shaggy on the outside, and we actually call those smudge cells. So this is an image of CLL, which is essentially that you have too many mature lymphocytes and they don't get the signal to die. And so what happens is they get so old, they're fragile and they smudge out. So CLL is a is a common type of mature non-Hodgkin lymphoma. And so certainly if you see smudge cells, this would raise our suspicion. Ultrasound, most people have had experience with ultrasound in their life, but essentially what this can tell us is whether a lymph node looks normal or abnormal. And we can not only do that, but we can measure it. We can take a biopsy of it using ultrasound. This is mainly for superficial lymph nodes, whereas a CT scan can really give us the whole picture. So we can look for enlarged lymph nodes, such as you see here in the armpits. We can see there's actually a conglomerate of lymph nodes here, appreciating, again, this is potentially not, CTs are not something that people look at routinely. They're actually commenting on the spleen here. So this can really give us a baseline and really help us to determine staging. And so, what I always tell people is that when you hear stage, people always want to know, am I stage 4? So, the staging, this is the standard staging system for lymphoma. A stage 4 in lymphoma can be very different from a stage 4 in lung cancer or pancreatic cancer. I just always remind people that even with advanced stage Hodgkin, for instance, our cure rates are still in the range of 70% or even more with the most recent regimens. So it's a very different kettle of fish. Additionally, there are indolent lymphomas that actually have very excellent survivals in the range of decades that commonly have stage 4 disease. So, while it is important and often can also tell us how risky the disease is, again, just take it with a grain of salt compared to, your expectations. So PET scans are also sometimes used. So these are helpful for certain types of lymphoma that are very active. And PET scans work by you actually get an injection of a sugar that's attached to a radio tracer. What you can see in the bottom is that this goes in through an IV. Cells that are growing, they need sugar, they need a food source. And so they take up the glucose that's attached to this radio tracer, or the sugar, and then it lights up. And so what this can do is it can actually tell us exactly where the lymphoma is. So again, this is only useful for certain types of lymphoma. It's really only funded usually after we have a diagnosis, and it can be used for monitoring in the middle of treatment and end of treatment, especially for aggressive lymphomas like Hodgkin or diffuse large B-cell lymphoma. This is just an example. So we actually end up with pictures like this, which is where we fuse this CT image with the lighting up from that sugar that's attached to the radio tracer, and it actually tells us a lot more information. This is actually a patient with Hodgkin lymphoma, and the stuff that's black is stuff that lit up. And so you can see this is his baseline. And so he had a bunch of lymph nodes that were lighting up. And then actually after 2 cycles of chemotherapy, all those lymph nodes didn't light up anymore. And so actually we would call this a remission. You have some normal activity just from, your heart needs sugar and it gets filtered through your kidneys into your bladder, and your brain needs lots of sugar. So it makes perfect sense. And then, what I always say is actually PET scans can be too sensitive. So in this case, he developed some inflammation in his lung. And what happened was that this patient had to be followed over time to make sure that this actually wasn't lymphoma. So, PET scans, again, grain of salt. It's really important to rely on our radiology colleagues when we're interpreting them. So biopsies, again, probably all of you would have had experience with biopsies. I'll just say again that a bone marrow gives us different information. We don't actually use them as much as we did before because really now we're of the mind that if they're not going to add to the diagnosis or change our management, then they're an uncomfortable procedure that we don't necessarily need to proceed with. An excisional biopsy is where a surgeon actually takes a chunk of tissue, which can be helpful if we're thinking about certain diagnoses, which can be a bit more challenging, like Hodgkin or T cell. A needle biopsy is actually where we're doing cores. So this is where we're using, you can see here the ultrasound probe, and it's just essentially a hollow tube, and usually there's 6 to 8 cores that are taken, and we can put that together under the microscope. Sentinel node biopsy isn't really relevant for lymphoma. So when we're taking the bone marrow, there's a couple different part. People have a lot of questions often when we're doing the bone marrow. So I always just let people know that bones are not solid. They would be too heavy. We wouldn't be able to walk around. And so inside them, there's this, it's called spongy bone. And essentially within that are these little islands where the blood cells are growing up. So you can see all of those different ones here, and there's quite a few stem cells. And so when we're doing the biopsy, we actually are going through this hard outer period, which is called the cortex, and we're going into this softer, spongy area. And what we do is we take a liquid part, which is called an aspirate, and we can do special testing on that and the special DNA testing. And then often we'll take a bone chip. And that gives us different information. So it really tells us about kind of the architecture, which is really important for staging lymphoma, are for identifying lymphoma and also grading lymphoma, which can also give us information about prognosis. We can also do special testing like immunohistochemistry. And really, I think an important thing to note is that there's different processing times. So sometimes we can have a preliminary result from the liquid part, and the core, the trephine, can take a bit more time. And again, previously we just looked at the cells and we said what they look like. Now we really have all this very specialized testing that we can do that looks at the genetics and the chromosomes and all the DNA, just to have a really good understanding and classify these cancers differently. So the next part people ask is, how am I going to do with this? So this is just briefly, prognosis is how we predict. So this is how we predict how you're going to do with your disease, if it's going to progress, what your likelihood for response is. We base this information off hundreds or thousands of other patients who've had similar diagnosis and gone through treatment. And all I'll say is just that everyone's unique. So everyone's lymphoma is a little bit different. And so just again, take everything with a grain of salt. Whenever people ask me for percentages, again, that's an average. So everyone can be a little bit different. Some people might do a bit worse and some people might do a bit better. We actually have these calculators, and essentially these are based off big studies of patients where they looked and said, what risk factors make this a riskier lymphoma? And what we can do is put that into a calculator, and often it'll give us a percentage of, how many people are going to respond to this treatment, how many people will be, progression free, which means that their disease hasn't got worse in 2 or 5 years. So this could be really helpful for, again, prognosticating patients based on the type of disease that they have. We have all different calculators for follicular, mantle, CNS, Hodgkin. There's websites devoted to them. So again, if you're someone who wants to be a bit more informed, this can be really helpful, is looking at what category of risk your lymphoma falls into. So putting it all together, it's really important to understand what type of lymphoma you or your loved ones has. Sometimes we do have to repeat biopsies, hopefully not, to really get the full picture. Staging tells us exactly where the lymphoma is, and that's usually based on the combination of tests we talked about. For prognosis, we can use clinical experience or scores to really, give you as much detail as you want or as possible, and then we can talk about treatment. And so the goals of treatment are different depending on what type of lymphoma you have. So again, those indolent lymphomas, we don't think necessarily we can cure them, but for those patients who do need treatment, the goal is to provide control of the disease, improve their quality of life, and make the longest remission possible. So again, the goal is if you need treatment, treat you, get you into remission. Hopefully it's 10 years before you need something new. For aggressive lymphoma, again, we're often trying to cure that lymphoma. If the curative treatment isn't possible, such as because of where the disease is, or sometimes in our older patients, it's a lot harder to give aggressive therapy, or because of other medical conditions, then we try to control the disease for as long as possible. And again, we're always considering involving our palliative care, supportive care colleagues for treatment. So this says treatment options for non-Hodgkin. Really, this is similar for Hodgkin lymphoma. And again, all of it is based on the information that we would have gathered before. But just to say that there's a lot of different methods that we can use for management, and this is where it's really important to be in conversation with your provider about what's important to you and your needs, and also taking all of that information that you got into consideration. So when we're talking about surveillance, the other name for this is watch and wait or watchful waiting. So we know that for those indolent or incurable lymphomas, so indolent usually meaning slow growing, sometimes these are diagnosed just they had a someone had a CT for something else and they were diagnosed with lymphoma. And for those patients who the lymphoma is small, it's not causing any symptoms, it's not likely to cause any symptoms soon. There's been lots of studies looking at if we give those people treatment early, when their lymphoma is not causing any trouble, can we make people live longer? Or by delaying treatment, is it less likely that they will respond? And what all the studies have shown is that there's no risk with delaying treatment until the lymphoma becomes symptomatic or is going to, we know is going to cause trouble based on the size and location. So, I always say if it's not causing any trouble, let's keep an eye on it, unless, people feel very strongly that they need treatment. The reason is all treatments have side effects. Even those that are pill therapies or targeted therapies, they all have side effects. And so if you're not having any symptoms, I don't want to trade that for you being on a therapy and having lots of side effects from that. I just reassure people that even if you're having surveillance, you're still going to be followed by your team every 3 to 6 months. You'd be having history, physical exam, lab work. So there is still very, close follow-up to keep an eye out on things to make sure that you're not going to have those significant consequences by pursuing surveillance in the first place. So actually, shout out to Lymphoma Canada. They have an excellent guide to watchful waiting. And actually, this specifically outlines when you would start treatment. And so these would be the questions that you would be asked at each appointment, and we would hopefully educate you on to monitor yourself for. So these are those B symptoms like you had before. If you noticed an enlarging lymph node, sort of unexplained pain in your chest or your belly, shortness of breath, blood count changes over time, those might all be signs that the lymphoma is growing, and that would be an indication, okay, the lymphoma is causing trouble, and now it makes sense to go ahead with treatment to try and get it responding and put it into a remission. And so this guide, I think, is available online. I put it there at the bottom, and it actually has a section for you to monitor your symptoms. So it's very helpful. And I would hand this to my patients in clinic if I was, we were discussing moving ahead with this strategy. So radiation, I know it sounds very old school, but actually this can be very appropriate for certain types of lymphoma. So especially if we have indolent lymphomas, again, we often think of them as non-curative. But if it's just isolated to one spot, like the armpit or the neck, we actually can treat that with radiation, and there is a chance of cure. Radiation can also be effective for certain types of skin lymphoma, for individuals who've had chemoimmunotherapy and their PETs are still positive in one spot, or even individuals who are not interested in having chemotherapy or can't, then we can use radiation. The good part about radiation in lymphoma is that we actually can use, it's very sensitive, and so we can actually use lower doses of radiation compared to a lot of other types of cancer because it's shorter courses of radiation, there's less side effects. And, if you think about how long that lasts, our standard treatment for follicular frontline is 6 months long, whereas the radiation would be 12 days long. So it can be much shorter if it's an appropriate indication. This is just very briefly, radiation is provided by radiation oncologists. You do usually have to get a CT in the radiation department, and then actually medical physics review the plan. They split it into a certain number of days, and by taking the total dose and splitting it into small amounts each day, we actually minimize side effects. And very rarely we'll do it twice a day. And so this is actually just a picture of what radiation looks like, and they essentially draw a line around where the disease is, and they figure out exactly where to shoot the beams. And so it's very precise, actually. The side effects are listed there. The main things that I warn people about are fatigue, and then it's sort of like a sunburn to the skin. So chemotherapy, again, is a classic treatment for lymphoma. It still forms the backbone of a lot of our treatments. And essentially, it works by affecting dividing cells. So as those cells divide and grow, which is, cancer cells are dividing and growing, which is how they're getting bigger, then it affects those ones. So this is why, dividing cells is also your hair, also your GI tract, your eyelashes. So that's why we can affect those as well. And then a lot of those chemotherapy drugs can also have sort of other effects, which is shown right here. So it can affect your nerves or your kidneys or your bladder or your heart. So it's always a balance between wanting to control the cancer and the side effects. And anytime you would be considered for treatment, you're always going to go through an informed consent process where your provider would be talking through all of those side effects, how to give the regimen, and things like that. We now, for a lot of different lymphomas, we would combine the chemotherapy with antibody therapy or immunotherapy. The name of the treatments actually comes from the first letters of the drugs, and these are just examples of different treatments. And again, all different chemotherapy drugs and given in different doses at different timing. And so again, this would all be part of the consent process. Just looking at my time. Perfect. So other treatments that we can use are stem cell transplants. So there's different types. So I'll just go over. So first is called an auto or a self transplant. And essentially, in a nutshell, this is giving really high dose chemotherapy. So it's a different type than what you would have seen before. For cancers or lymphomas that we think we probably won't get a long-term cure or disease control with our standard chemotherapy or treatment that we have. And so what we can do is we give them this high dose chemo, and then we give you the stem cells back, and they actually find their way into the bone marrow and grow up and make normal immune cells. And so by doing that, we don't have the side effects where the blood counts are low for months and months after the chemotherapy, but we can still give this high dose chemotherapy to hopefully wipe out all of the cancer cells that might be still in the body. This is a very involved process. It's at a transplant center. There's a family meeting where we walk you step by step, through the treatment process. Nowadays we can do a lot of these as outpatients for various reasons. Sometimes they're inpatients. I will say that for a lot of lymphomas, though, it's actually becoming less and less common because of the targeted or immunotherapies that we have. So rarely we will do what's called an allo transplant, which is where we use a donor cell. There's very different side effects, such as there's a higher risk for organ damage or infections. Patients can get graft versus host disease. There's a need for close long-term monitoring. This also usually requires you to see a different type of blood cancer doctor in a transplant center, because a lot of the times us lymphoma doctors do auto transplants and CAR T, but we don't do these allo transplants. So it's just sort of a team process. The goal can be cure it in some cancers, such as later stage CLL or hepatosplenic lymphoma. But again, these are quite rare in lymphoma. And I just always direct people to Canadian Blood Services or blood.ca if you have anyone who's looking to become a stem cell donor or blood donor or platelet donor or any of those other things that we need. So I know there's a targeted therapy talk later, but I just want to highlight. So this is actually from a 2022 paper. And even since then, there's been a whole bunch of new, discoveries, approvals, things like that. And so what we've really realized is rather than just killing cells, just across the board, is now we can look at what proteins they expressed on the surface. So you can see that here. We can look at how we can cause the body's own immune cells to come and attack the cancer cells. So it's really a lot more about, rather than just widespread killing of any actively dividing cells, is really how can we make it a lot more specific. And so, I'm not going to go through this, but essentially we have these antibodies that just stick to one protein. We have CAR T, which a lot of people would have heard of before. And there's a whole bunch of different products for that. We have now bispecific antibodies. And these are the ones that are just for lymphoma, never mind, myeloma or other types of blood cancers. And in Hodgkin too, we have several funded, Health Canada approved, targeted or antibody therapies. So it's really, treatment has really changed in the past 10 years and will just continue to evolve. And we really see that with CLL. So this is one of our success stories. So again, this is very complex signaling that happens within the cancer cells. But just to say that they essentially looked at each step along the way and said, how can we block this? How can we block this? What can we combine together to get the most effective therapy that we can get? And previously, again, we would have just we had a couple drugs, we had steroids and some chemos and just the one antibody. Presently, again, we have all these different therapies, a lot of them which are oral, appreciating that people, we want to maximize people's quality of life, that target all these different things within the cell. And in the future, there's going to be even kind of more options. So just really looking at how can we have the best response with the least side effects, the least cumbersome to patients, to try and sort of minimize how much time you're sitting in a chair with an IV in your arm. CAR T is similar to that. So it's a kind of one and done, and I'm assuming probably there will be a CAR T talk at some point. But this is actually a method that is used in some lymphomas, usually after second or later line. And we use this when we think, okay, chemotherapy doesn't seem like it's going to achieve really a lasting response. Targeted therapy is no longer effective or is not felt to be the most effective method. So maybe we can use a different type of immune therapy where we actually take your own white blood cells. We send them off to a manufacturing lab, which is currently all in the US, but I'm sure that we will have manufacturing facilities in Canada anytime now. And sorry, there is one for a clinical trial. We actually insert this targeting sequence, we grow the cells, and then we put them back in your body. And so actually those cells, they seek out the cancer cells. These are your own white blood cells, and they actually can seek and destroy the cancer cells. There's different side effects. Again, everything comes with side effects because as they're expanding and causing lots of inflammation, that can have its own issues. And again, once we put them in, we can't take them out, but certainly we're very excited that we have some options with regards to CAR T for the future. Excuse me. So my takeaways are: ask questions. I love being asked questions. I really, I try to use a method where I ask people's understanding and then I try to check in and make sure that they understand so we're on the same page, because I think the most important thing is just feeling empowered about, your cancer and how to treat it, and understanding everything about it. Again, with whatever level of detail you prefer. The initial workup is going to feel very extensive. It'll include probably imaging and biopsies as well as blood work to correctly stage and prognosticate your lymphoma. Therapy is rapidly evolving. Again, for my patients who are going on surveillance, they often ask me, well, what am I going to get treated with when I progress? And I say that the standard of care may have completely changed because of the rapid pace with which we're developing all these treatments. So I just say, ask me when we come to it, because we'll see where we're at. And then lastly, just always consider clinical trials and patient advocacy. If interested, this is how we kind of move the needle and how you can support, fellow Canadians who are going through the same journey together. This is just, again, going back to the Lymphoma Canada website. There's all these different booklets that you can have that sort of have a really good summary. We have them in our clinic and we hand them out to all patients, going over, again, all the different therapies, and there's some specific to CLL, for instance. There's a Waldenstrom handout, etc. And I just want to say thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Davies, for that great introduction on lymphoma. So just a reminder to the audience, if you have a question, please be sure to enter it in the chat and we'll try and get to as many as possible. We did have a question come in asking about rituximab. Is this an older therapy or is this a current targeted therapy that's used in practice?
Yeah, so that's a really good question. So rituximab really changed the game for B-cell lymphoma, and it's been funded in Canada since 2003. And so there's definitely been, so rituximab is considered like first generation, and then they've attempted to improve upon it. There are some lymphomas where the newer versions of rituximab have shown an improvement, but actually rituximab is still quite a good therapy that we use very frequently. So we use it pretty much for all our indolent lymphomas. We use it for hairy cell leukemia. We use it for DLBCL, Burkitt, primary BD-sentinel. So there's just a lot of different types. We're actually using these later generations didn't result in any difference. So yeah, we're very happy to have rituximab.
Thank you for that clarification. Next question we have here is, what should I know about vaccination and infectious disease management during and after treatment?
Yeah, also a very good question and very pertinent considering what time of year it is. So, the main thing I say is that, the lymphoma itself can affect your immunity. And so, it's always a very good idea to get vaccinations routinely, also to protect others, but also if you know you're going to undergo therapy, it's a great idea, especially to get your flu and COVID vaccines. We do know that with some treatments, it's not safe to get a flu or COVID vaccine right away, such as CAR T or transplant. So usually we start the revaccination process at 3 months after, and I would just sort of advise you to talk to um, your provider about that. And then certainly rituximab can, because we're actually affecting your white blood cells, and your white blood cells are the ones that respond to the vaccine. So we do know that it reduces the efficacy of vaccines, but we do actually still recommend that people get vaccine, because even if you get a bit of benefit, it's really gonna sort of hopefully improve your outcomes afterwards. But yes, we still, it's a good thing to think about, especially with it being cold and flu season. If you're getting therapy, wearing a mask, hand hygiene, asking people that you spend time with to inform you if they're sick, all those things are really good measures still. I'm seeing some other questions in the chat, so I'm not sure if I should go ahead and take those. So if indolent lymphoma has spread to the spinal cord, what is the likelihood that targeted treatment can attack those cancer cells in that harder to reach place? So that's a really good question. So it really depends on what the targeted therapy is. So some antibodies are too big where they can't actually get into the fluid around the spinal cord, although they sometimes, it's funny because, or not funny, but it's interesting because cancer cells can break off and float around in the blood, even if they're in the brain, for instance. So we give rituximab, which is this big drug, which we don't think can actually get to the brain, but it might help mop up anything that's floating around. So I think it's really important. Things like ibrutinib or acalabrutinib, we do think do cross into that the fluid around the brain. So it's just a very important question to ask your provider, and certainly, they would have to talk about which specific therapies we think can penetrate that area. I see a question about an individual who's diagnosed with lymphoma and the risk to your children. So yeah, again, we do think that there is a slightly increased risk to your children, but again, I would say if you look at that study I presented, the odds, because what they show is the odds ratio, the odds of your children having a blood cancer are probably between 1.5, 1.6. So it's not like they automatically would be at risk, but certainly it's a good thing to bring to the attention of their provider so that they can proceed with any screening.
Thank you, Dr. Davies, for taking Q&A over. My internet had cut out for a second.
No worries.
And that looks like about all the questions we have here for this session. Dr. Davies did mention some of our patient resources like our watch and wait guide, as well as our subtype fact sheets that was on the image on the previous slide. If you are interested in looking more into these resources, you do have the option on our conference platform to download them or send them to your email. So I encourage you to look or visit that tab afterwards. I would now like to direct the audience to attend the next session titled Lymphoma in the AYA population, which is essentially the adolescent and young adult population. This session will then be followed by a session on targeted therapies, including BTKI inhibitors and bispecific antibodies and more. So thank you everyone, and I hope to see you in the upcoming sessions.